I had a bit of fun with this talk. I generated some new data on magnesium because the data that I found I didn't like. And so, first of all, I have no conflicts of interest. No company pays me to talk about magnesium. Magnesia, the name magnesium, comes from this district in Greece where it was first found. I don't believe that it was found there. I just believe that the name's kind of stuck. In 1600s, Henry Wicker tried to feed this slurry from a well to his cows, and the cows, of course, didn't like it. And then he rubbed it on his skin, which became Epsom salts. Strange story, but there was this entire industry in Epsom where Epsom salts are actually still available, and they're magnesium sulfate. Joseph Black recognized magnesium as an element in 1755, and Sir Humphrey Davy isolated magnesium via electrolysis using this voltaic pile, which is essentially a battery, in 1808. I can't even imagine what it was like to work with this thing and not electrocute yourself. So magnesium is one of these things that we just never really talk about in the hospital. We have one senior practitioner who really pushes magnesium, and it seems like he's the only one in the entire faculty that embraces it and loves it, etc. Magnesium is very important. Well, magnesium is hot, right? Magnesium shavings are flammable. They can burn in water if you light them and then put them in water. The magnesium will still burn. It burns at like 5,000 degrees Fahrenheit, and it's the white light of fireworks. This is actually a magnesium stick, and that's a flint. And so what you do is you shave this, and then you light the flint with this thing, and you can even light this is actually accessory for a fireplace. So a bit of fun. Magnesium's also really cool because in 1957, Chevy made a Corvette and raced it, and this was a magnesium-bodied car. I have the video, which I won't play, but after this race, had this new lap record, was really fast, and then the car broke down, so they never made it. But at any rate, magnesium is also the 8th most abundant element in the universe, so it is actually important, not just in us, but everywhere. It's present in every cell type, in every organism. ATP must be bound to magnesium ion in order to be biologically active, and there's over 300 enzymes that require the presence of magnesium for a catalytic action. No hormones have a substantial role in regulating magnesium. So magnesium is essentially treated as expendable, and it's like an orphan, which I found surprising when I was doing this talk. So the objective, we're going to talk about magnesium balance, hypomagnesemia, hypermagnesemia, and then I'll generate some outcomes data on hypo and hypermagnesemia and present that to you. So the normal range depends on where you are. We use milliequivalents per liter, and when I present the new data, that's what I'll be talking about. But there's a conversion in terms of converting milliequivalents to liter to millimoles per liter and milligrams per deciliter. In the data set that I have, some of the data comes out as milliequivalents per liter and some comes out as milligrams per deciliter depending on the year that I actually access the data. The average daily mag intake is 360 milligrams, and 130 of that is absorbed, principally in the small bowel, through saturable transporter system and passive diffusion. Secretion of approximately 40 milligrams is in 2 intestinal secretions. And then there's absorption of another 20 milligrams in the large bowel. Well, but where the money is in urinary excretion. There's approximately 100 milligrams of magnesium that is absorbed, and the kidney itself is the major regulation point is urinary magnesium reabsorption in the loop of Henle and the distal tubule of the kidney. So in terms of hyper and hypomagnesium, it's mostly a kidney issue, and we'll get into that. So hypermag inhibits magnesium and calcium urinary reabsorption, while hypomag stimulates magnesium reabsorption in the kidney. And hypercalcemia also inhibits magnesium and calcium reabsorption, leading to hypermagnesiuria and hypercalciuria. Decreased reabsorption and mag wasting can be induced by accelerating this by using a loop diuretic, which inhibits sodium and chloride reabsorption. And then chronic use of thiazides is associated with hypomagnesemia and renal mag wasting. In terms of magnesium balance, metabolic alkalosis stimulates magnesium reabsorption, and metabolic acidosis, hypokalemia, and phosphate depletion inhibit magnesium reabsorption, all in the kidney. What's interesting is bone magnesium is the principal reservoir of magnesium, but it doesn't rapidly exchange with circulating magnesium. So plasma magnesium concentration can actually fall quite rapidly with the negative magnesium balance, and that's what we see in the ICU. And this leads to this marked reduction in magnesium excretion, provided that urinary magnesium wasting is not present from a pharmacologic or kidney issue. So let's talk briefly about hypomagnesemia. The incidence is high, about 60% or so in the ICU. Nutrition and diuretics and hypoalbuminemia, aminoglycosides all may play a role. Hypomagnesemia begins to occur after a relatively small magnesium deficit, because we talked about this little exchange of extracellular magnesium with the large bone and cell stores. It's often associated with hypokalemia due to urinary potassium wasting and hypocalcemia. We also see it in GI losses, renal losses, and other. Gastrointestinal secretions contain some magnesium. Potential losses are continuous and not regulated. Marked dietary deprivation can lead to progressive magnesium depletion. And mag depletion is more commonly due to diarrhea than vomiting, and that's because of the mag content of the lower secretions is significantly higher than in terms of up to 15 milliequivalents per liter versus 1 milliequivalent per liter for the upper tract. So in patients with acute or chronic diarrhea, malabsorption, and steatorrhea, and small bypass surgery, magnesium can be a factor in terms of hypomagnesemia. In terms of the renal, we talked a little bit about loop and thiazide diuretics inhibiting net mag reabsorption. Case-sparing diuretics may enhance magnesium transport and lower magnesium excretion, but the thing that you're going to see is recovery from tubular dysfunction. So loop and thiazide diuretics may be common in the ICU. In the patients that I see almost exclusively acute kidney injury patients. So those patients who are having a recovery from acute tubular necrosis will have a massive potential magnesium waste. You also see that in renal transplantation as the graft recovers, and also in post-obstructive diuresis, which is more dramatic but also less common. Same sort of thing in terms of nephrotoxic acute tubular injury, in particular urinary mag wasting. This is classically seen in cisplatin. But you'll also see it in some aminoglycoside antibiotics, Ampho-B, pentamidine, cyclosporin, and then some of the MABs in terms of the EGF receptor antibodies that are being used. Alcohol is something that I'll see, and this is one of my favorite teaching points when I have a patient who has alcoholism and has magnesium wasting in terms of being able to talk about magnesium. It's an elegant, reversible proximal tubular dysfunction. There's excessive urinary excretion of magnesium. And the issue is the patients have to be abstinent from alcohol for 3 months, I think it is. So it's very difficult for those patients, not all alcoholics have this, in terms of correcting their magnesium. Uncontrolled diabetes mellitus leads to urinary excretion with hyperglycemia. Other reasons, saponification of magnesium occurs in acute pancreatitis, refeeding syndrome in malnourished patients, which we talked about with phosphorus. And then this chronic use of omeprazole with diuretics is really plus minus. It's talked about, but the evidence for it isn't very good. Symptoms of hypomagnesemia: unexplained hypocalcemia, refractory hypokalemia, neuromuscular disturbances, and then ventricular arrhythmia. So it can potentially be an important problem. Hypermag, primarily seen in 2 settings: poor renal function or with large mag loads, IV, oral, or given in enema. There's no protection against hypermagnesemia with loss of renal function. So we talked and said that this really depends on the kidney itself. So in this setting, continued intake leads to mag retention that's predominantly in the extracellular fluid. And that's one of the reasons why milk of magnesia, which is a magnesium-containing slurry, is in general contraindicated in dialysis patients. And that's one of the first lessons our renal fellows learn, is to stop all milk of magnesia for all dialysis patients. Other causes: diabetic ketoacidosis, hypercatabolic state, lithium ingestions, milk alkali, adrenal insufficiency, and I couldn't really understand why the adrenal insufficiency would be associated, but it was there, so it's in the talk. Symptoms: severe neurological manifestations such as paralysis, somnolence, and coma, cardiovascular manifestations, bradycardia, and hypotension. Treatment depends on the kidney function. So if you have normal kidney function and you have hypermagnesemia, the treatment is to stop the source of MAG. If you have chronic kidney disease or moderate AKI, the treatment is intravenous fluids and loop diuretics to try to increase MAG excretion. If you have end-stage renal disease or severe acute kidney injury with anuria, intravenous calcium as a magnesium antagonist to prevent some of the cardiac manifestations, and also hemodialysis. I have never dialyzed for hypermagnesemia. Hypermagnesemia that would promote me to think about dialysis is excessively rare. This is the data on outcomes, and it's not just hypomagnesemia, it's magnesemia, hypo, and hyper. There's essentially 3 studies, all are relatively small, and all show unadjusted in-hospital mortality, where it looks like there are differences in mortality in terms of patients who have high versus low magnesium. Some of them looked at ionized magnesium, some of them looked at non-ionized magnesium. But it looks like there might be something there, but there's no adjustment for any of the other cofactors involved. So I said, well, I have a large data set, so let me look at magnesium. And I did it specifically for this talk, so it's not perfect, but I think it's a pretty good start. In terms of designing the study, I have an exposure, I have an outcome, and I have confounders. So it's a very simple type of study design, but hopefully it gets the message across. The exposure of interest that I chose was the lowest magnesium in the 24 hours prior and 72 hours after ICU admission. Patients were included who survived up to 72 hours after ICU admission. I got rid of the dialysis patients because they're going to probably be the ones with hypermagnesemia, and the number of patients, critically ill patients in the cohort is 81,000, a little higher than the previous studies. The primary endpoint was 30-day all-cause mortality, and we have 100% vital status follow-up at 365 days. The study schema: MAG was measured in this narrow window, and then mortality was measured for a year. I used logistic regression to try to take into account the particular confounders that I thought would be associated with both MAG level and with outcome. And in terms of the levels, we have, this is our normal level, 1.4 to 1.7 millicolumns per liter, about 50,000 of these. This is considered hypermagnesemia, although that's a pretty low bar for hyper. We have 17,000, and then the hypo is 14,000. In terms of the 30-day mortality rate, unadjusted, which you can see is you see a little bit of an increase in mortality with the low group. This is the, quote, normal group, 8.1% 30-day mortality, and then the higher group has an 11%. In terms of nutrition status, I did a subset analysis of 6,000 of these patients to see, well, is low magnesium just a nutrition marker? And what we find is that although the ANOVA is significant because the number of samples is relatively high, it doesn't seem that practically different in terms of 176, 176, and 170. No malnutrition, nonspecific, and then actually quite severe malnutrition. So it doesn't look like it's just a nutrition issue. When we look at our Kaplan-Meier results in terms of the unadjusted data, what we see is this is the group with higher magnesium. This is the normal group, and this is the low group. And so what you're seeing that the split itself happens somewhere in the 15-day range, and the slope of the curve after a hospital discharge for survival is essentially about the same. So looking at the odds for 30-day mortality with magnesium, what we see is we see a signal in the low group, although it's actually quite small. So an 11% increase in mortality, which is statistically significant, most likely because we have this overwhelming sample size. When we look at the higher magnesium group, we do see a more robust odds ratio of 1.46, so 1.5-fold increase in mortality if you're MAG level. And this is, again, the lowest magnesium level that I measured in that 3-day window in the first 3 days of ICU. When I adjust for age and gender, race, patient type, Deo-Charlson Index, acute organ failure, chronic kidney disease, and sepsis, what I find is the association is still there. It's a bit attenuated, but this is completely eliminated in the low group. So it looks like if I adjust for these particular factors, I'm not seeing any mortality difference in the hypomagnesemia group, but the hyper is preserved. When I focus on the medical patients, again, the low values, I don't see an association in terms of outcome, but I see a more robust association in terms of mortality in patients with higher magnesium levels. And I did this adjusting for sepsis, chronic kidney disease, acute organ failure, et cetera. And then I also threw in the rifle term to see if this was just an acute kidney injury issue, and the odds ratio essentially stayed about the same, about 1.58 or so. So, in conclusion, the major regulation of magnesium occurs in the kidney. Plasma mag concentration falls rapidly with negative magnesium balance, and elevated magnesium levels above normal appear to be associated with mortality. And the treatment in terms of treating high magnesium really depends on the patient's renal status. And hypomagnesemia doesn't really appear to be associated with mortality. My guess on that is that we replete hypomagnesemia, and we can replete it relatively easily. And so in the hospital, in the ICU, if we left the patient hypomagnesemia and didn't intervene, maybe there would be an outcome difference. But in terms of it's an easy ion to replete, it's repleted, and that's probably why I don't see an outcome difference in the low group. That's it. Thank you very much.